right, so we're going to talk about musculoskeletal system tonight. Um, as with all of the previous weeks, we'll see mostly CPC. We'll have some ICD-10 thrown in here with it as well. Um, but musculoskeletal is going to be our 20,000 series codes. And most of your codes are going to be broken down or grouped together by the anatomic location, and then different procedures that are performed on those different anatomic locations and groupings. So that's the big thing to remember with all of your musculoskeletal codes, is just make sure that whatever procedure you're doing, whether it's a repair, internal fixation, things along those lines, make sure that we're looking at the correct location and the correct bone that it's being performed on. So that's the big thing, and that's where it's easy to kind of get a little bit mixed up and thrown around in this section. So let's just start off with number 1. So we've got a patient fell and fractured his femoral shaft in 3 different places. The fracture is treated with an ORIF of the left femur with an intramedullary nail and interlocking screws, and those were placed peritrochanterically. The orthopedist also has placed the leg in a plaster splint prior to leaving the OR. So first off, we want to kind of break this down a little bit. Does anybody know what ORIF stands for? You can either come off of mute, you can type it in the chat if you want to. Does anybody
Isn't
know what? Go ahead.
isn't open reduction internal fixation, I think?
Yep, that's it. So it just means that they've done an open reduction of that fracture, and then they use internal fixation. So they use plates and screws or something along those lines to fix that bone so that it doesn't move back during that healing process. Okay. So when we're looking at this from an alphabetic standpoint, or the alphabetic index standpoint, when you're looking at fracture treatment, instead of looking at the type of treatment that is being done within the alphabetic index, it's always easier to look at it main term fracture and then the location of the treatment. And then we'll go narrow down our codes from there. So let's go to main term fracture. What anatomic location are we going to look at for the fracture treatment? The femur. Yep, absolutely. So we have the femur. And then underneath femur, we'll look at the term for peritrochanteric, because that's where the screws and that nail were placed, right? So when we're in the alphabetic index, we found our anatomic location for the femur. Now we're talking about the fracture treatment. So we're talking about that peritrochanteric area of the treatment. And then again, what type of treatment did we have? So of your couple options that you have underneath your peritrochanteric entry, what, okay, so Myra says open, which yes, we did do open. However, there's a word in here that gives us a little bit more specific type of treatment that we did. It's because we did the intramedullary nail. That's going to be an intramedullary implant shaft. Yep. So that's going to give us a couple codes that we need to go look at. So let's go look at the 27245. Let's look at that one first. So our code description for the 27245 is the treatment of an intertrochanteric, peritrochanteric, or subtrochanteric femoral fracture with intramedullary implant with or without interlocking screws and or cerclage. So it has all of our keywords. However, make sure that you're paying attention to the way that those words are used. So the 27245 is telling us that the fracture is intertrochanteric, peritrochanteric, or subtrochanteric. However, the fracture itself is of the femoral shaft. Okay, do you guys see that? So the location of the fracture and the location of the treatment are two different things. Okay, so the location of the fracture is the femoral shaft. So 27245 would not be it, because this is telling us that the location of the fracture is intertrochanteric, peritrochanteric, or subtrochanteric. So 27245 is not our code. Does everybody see that? Okay. So the next code that we need to look at is 27500, 27502, 27506, and 27507. So let's go to the 27500. So 27500 is for a closed treatment of a femoral shaft fracture. So we have the location of the fracture is correct, but the type of treatment is incorrect. So 27500 is not correct. 27502 is again closed treatment for a femoral fracture. So we can keep going past that one. 27506 is for open treatment. So we already know that part is correct. Femoral shaft fracture, another portion is correct because it's the correct location of the fracture. With or without external fixation. So here we don't have any documentation of external fixation, but because this code description says with or without, then we can still use it. And then it says with the insertion of an intramedullary implant, which is going to be our intramedullary nail and interlocking screws. So that portion we're checking off on that one again. And then with or without the cerclage and or locking screws. So we've got all of our pieces. Does everybody see that? So the 27506 is our correct option. Any questions on that? Why are we not also coding the plaster splint that was coded or that was placed prior to leaving the OR? Why are we only coding the fracture treatment and not the splint placement?
Isn't that,
Anybody know? Go ahead.
isn't it already included with the treatment?
Yep. Yep. So that initial, you've got a guideline around your casts and strapping. So if you have the 2024 version of the CPT, it's on page 200. You've got a guideline that states that it includes the application and removal of your first cast, splint, or traction device when it is applied. Now, if you have multiple splints and casts that are applied, then your second, third, and fourth can be billed separately. But that initial splint or cast or strapping is going to be included in the procedure code. So in the testing environment, they might give you an option that has the correct procedure code, and then they might say whatever the code would be for the plaster splint. So, Mayra, if you have the 2024 manual, it's on page 200. And your guidelines directly underneath the application of cast and strapping headline. Okay. Any questions? Okay, you have 2023. Let me pull out my 2023 really quickly. It should be close to that 200 page mark. Let's see if I can find it really quickly for 2023. It's page 195 in 2023. Okay. Let's go to number 2. Patient is given a xylocaine, which is a local anesthetic, by injection in the thigh above the site to be biopsied. A small bore needle is then introduced into the muscle, goes about 3 inches deep, and that muscle biopsy is taken. So what CPT code should we report for that? So what is our procedure that we're performing to look at it from an alphabetic standpoint? Biopsy. Yep. So let's go to main term biopsy. Where is the biopsy taken? Thank you guys for giving Charmy that page again. So the biopsy is taken of the muscle. So we did a muscle biopsy. So you'll go to biopsy and then muscle. And then it gives us a range of codes for 20200 through 20206.
Okay, I have a question.
Yeah.
Why not biopsy and then thigh?
Because the muscle is, because we're not taking a biopsy of the tissue of the thigh, right? We're taking an actual muscle biopsy.
Okay. Okay, thank you.
Yep. You're welcome. Absolutely. That's a good question. I'm glad somebody did ask that question, because that's a pretty common question that a lot of people have. So we have 20200 through 20206. So of the 20200, 20205, and 20206, someone tell me what code you think we should use. Whether you can put it in the chat, you can come off mute. Somebody just tell me what option you think we should use.
Is it 20205?
Okay. So 20205, are you using that because we see deep in the scenario?
Yeah.
Okay. So your 20200 and your 20205, those are incisional biopsies. So those are going to be when we actually take a scalpel and we cut into the tissue and we go down to the muscle and take that biopsy out with an incision. 20206 is a needle biopsy, right? You see where it says percutaneous needle, and because we used a small bore needle, then that's going to be considered a percutaneous needle biopsy. So they threw that word in there. They threw this detail in there about 3 inches deep to see if you were paying attention to the fact that the 20200 and the 20205 is incisional. So make sure, if you guys want to, right next to the 20200 and 20205, that those are incisional, right? And then your 20206 is going to be your needle, which is what the correct answer is. Does everybody see that? Does everybody see why we're not using 20205. Does that make sense?
Yeah, makes sense.
Okay,
Thank you.
good. You're welcome. So this is an example of how sometimes they're going to give you detail that is pointless, right? Sometimes this detail might mean something, but just make sure you're paying attention to those descriptor words in the code and then matching them up with the detail that's here. Okay. Move on to number 3. We have a 63-year-old man that presents a neck mass or with a neck mass to be excised. The mass was palpated. An incision was then made and carried down through the dermis with electrocautery. The subcutaneous tissue of the skin was opened, encountering an organized mass with a benign appearance of a lipoma. Using careful, blunt, and sharp dissection, the mass measuring 5 centimeters was completely excised around its entire circumference, leaving the capsule intact. The mass was then removed from its posterior attachments using electrocautery. So what is it that we are performing? What's our procedure that we want to look up in the alphabetic index? Yep, the excision. Yep, so here we've talked about how we've completely excised, leaving the capsule intact. So if we go to main term excision, and then where are we performing the excision? What is our anatomic location? Neck. Yep. Because we've got a neck mass. And then underneath neck, we only have one option. That is for a tumor. So we've got a couple codes, 21552 and then 21554 through 21556. Let's go to 21552. So you'll see that those are out of order and they're just kind of jumbled in there with the 21554, 555, and 556. So they're all right there together. So what's the difference between the 21555 and that family and the 21556 and that family? What's our different, what's the term that's basically telling us that this family is different than the other family? Not necessarily the size. Yeah, so Myra's right. The subcutaneous versus subfascial. So that's going to tell us whether we need to choose bubble 21555 or the bubble for 21556. So in this instance, did we do a subcutaneous or did we do a subfascial excision? So how deep did we go to remove the mass? Yep. So subcutaneous, right? So they tell us that the subcutaneous skin was open, and at that point we encountered the mass. Okay. So subfascial is going to go underneath that the cutaneous layer of the skin, and it's going to actually go down into the muscle and all of that. So that's what our subfascial means. So for this instance, we had a subfascial excision, or sorry, subcutaneous incision. Sorry, I said that backwards. We had a subcutaneous excision. And then what was the measurement of that excision or the max that we excised? Because we know our 555 is less than 3 centimeters and 552 is greater or 3 centimeters or greater. So yeah, we had a mass measuring 5 centimeters. So that's going to give us 21552. Okay. Makes sense. Any questions on that one? Okay. So number 4, you can see that we've got some HitPix codes thrown in here. Yeah.
Tiffany, I have one question. What's that hashtag next to the 21552 mean again? I'm just,
What does the pound sign? It just means that it's a resequence code.
okay. I knew it was something. I just couldn't think about it. Okay.
Nope, you're fine.
Thank
So
you.
if you ever see a symbol that's over there, you can look in 2 different places. You can either look at the bottom. You see at the bottom of your pages 142 and 143 how they've got all of what your symbols mean.
Yes.
So you've got them there. If for some reason you see a symbol that you're not like completely sure what it means and it's not down there in the introduction at the very, very beginning of the book, then it has a full list of all of your code symbols.
Okay. Thank you.
You're welcome. Absolutely. All right. So number 4, we have a 42-year-old with chronic right trochanteric bursitis, and they're scheduled to receive an injection at the pain clinic. So a 22 gauge spinal needle is introduced into the trochanteric bursa, and a total volume of 8 cc's of normal saline, and then 40 milligrams of Kenalog, which is triamcinolone acetonide, that is injected. So let's actually look at your HitPix book first. Okay. So does everybody know how to find the HitPix code that correlates with a drug? I know that our code is the same in all 4 of the options, but I want to make sure everybody knows how to use that table of drugs and biologicals that's in the back in one of the appendices. Yeah. So you'll go to that table of drugs and biologicals, and then you'll look it up. If you have the AAPC version, it's Appendix A. If you have Decision Health, it's Appendix B. I don't have an Optum, so I can't tell you for sure which appendix it's in, but it's always going to be back there in your appendices stuff. So when you're looking at your appendix or for your table of drugs and biologicals, you want to look for your drug name in that first column. And then your second column is going to be how many units are for each unit of the code. The next column is going to be for the route. So whether it's oral, intramuscular, intrathecally, intravascularly, subcutaneously, all of those. And then your last column is your actual HitPix code. Now, as always, don't code directly from your table of drugs and biologicals, especially if you have Decision Health. I have found multiple typos in the table of drugs and biologicals in Decision Health. So make sure that you always verify your code in the tabular portion of the code list. Okay. So we have J3301 for that Kenalog. So let's go look at our J3301. Look at our code description. Make sure it all matches. But then we need to also look at how many units of the drug are per unit of the code. So J3301 is for your injection of your triamcinolone acetonide, at which underneath it says your drugs are your Kenalog and your Kenalog 10. And it's per 10 milligrams. So if we have 40 milligrams of the Kenalog that's injected, how many units of J3301 should we report?
4.
Correct. Yep. So our J3301, we're going to report 4 units to make sure that we're getting paid for all of the medication that was administered.
Quick question on the Kenalog.
Yeah.
J3301, it says drugs Kenalog 10, Kenalog 40, and Kenalog 80.
Mm-hmm.
So would the Kenalog 40 be there to confuse us?
No, the Kenalog 40, that's just going to be one of the brand names that's out there.
Okay.
Yeah, so some of your scenarios might say 40 milligrams of Kenalog 10, right? To see if you're paying attention to the amount of milligrams that are administered or to the amount or to the name of the drug, right?
Oh, I see. Okay.
Yeah.
Oh, I
So
see.
just always make sure that you're paying attention to the milligrams that are administered versus the milligrams that are in the code description. Yep. It's very easy to confuse and mush together, especially when you're taking your exam. It's very easy to just say 10 and 10 and 40 and 40 and, do what you got to do. But just make sure that you just kind of take a breath and look at it, and you're not looking at the 10, the 40, or the 80 in the name, and you're looking at the actual milligrams that they've administered. Yep, good question. Okay. So now we need to look up the actual injection code, right? Our HCPCS code is only going to represent the medication, but we need our code for the actual injection. So we can look at this one from a testing standpoint, right? So we know that we've already eliminated B and D. So let's go look at the 20610 versus the 20550. Look at the differences between those codes and figure out which one matches our procedure that we have described. So 20610 is going to be for an arthrocentesis, aspiration, or an injection that's done in a major joint or bursa, which includes your shoulder, your hip, your knee, or the subacromial bursa. And then it's without ultrasound guidance. So since we did the shoulder, right, because that's where our trochanteric bursa is, then that's part of the shoulder. So that's going to be a major joint. So that matches that code description. Let's go look at the 20550 just for S's and G's and make sure that we are paying attention to the differences, because they may be ordered different, and you may look at the 20550 first instead of the 206. So the 20550, that code description is for an injection of a single tendon sheath or ligament aponeursis. So even though it's for an injection, right, you don't want to stop at that word. You want to make sure that you're actually matching the rest of the code description. So they did not inject into a single tendon sheath or a ligament aponeursis, right? We injected straight into that joint, that major joint for that trochanteric bursa. So we're going to use, let me make this a different color. So we're going to use the 20610, and then we would append an RT modifier to indicate that it was done on the right shoulder. So with your musculoskeletal system, if you have two of a joint, two of, like obviously when you do fracture treatments on legs, they give us the information we should use from a correct coding standpoint. We should use modifiers to indicate left or right. Just from an insurance standpoint, they like to see it to make sure that we're not performing multiple surgeries on the same leg. Okay. So any questions on number 4 as far as the injection and or the medication that's injected?
I have a question.
Yeah.
It's about the shoulder.
Nope, you're good.
Besides knowing your whatever that word is, the trochanteric is the
Mhm.
shoulder. Say we space it on the test. What would you suggest? How do we find out that's the shoulder? Is there any shortcuts besides going to the front of the muscular section that's not on the diagram of the skeleton there? Any help with that?
Mm, my
No.
only suggestion would be to go back to the alphabetic index and see if that would give you your location too.
Oh, okay.
Because sometimes your alphabetic index will kind of guide you in the right direction. Sometimes, not always, but sometimes.
Okay, thanks.
Yeah, you're welcome. Now, from a testing perspective, right, we know that if we were to look at, and we know that because we knew we had to have 4 units of that J3301, right? We know it either has to be an injection of a major joint or an injection of that tendon sheath. And we know that we did not do the tendon sheath, right? So that's another way that you can be a little bit more confident in your answer.
Okay, let's just say C was 20605, and that has to do with like the wrist or the elbow or ankle or something like that.
Yeah.
You just kind of have to guess then, right?
At that point, that's where your anatomy knowledge is going to be
Yeah.
a lot more beneficial. Yeah.
Okay, thank you.
Yeah. You're welcome. Absolutely. Now, if you want to, because we've seen this question, right, in next to the 20610, because if you think, hey, I might see trochanteric bursa and I may not remember that that's the shoulder, you can also write next to it trochanteric bursa,
Perfect.
right? So you can write anything and everything you want. So as you're going through practice questions, practice exams, whatever it is, if there's anatomic information that you know, hey, I may not remember that this is this on the exam, you can write those terms. Now, you can't write this question. You can't write the rationale that's in the answer key, right? If you get caught with that during your exam, then you can get ejected from your exam and barred from taking it again. Okay, so that's why you have to be careful about what you write into your book. But basically, the only things that you cannot write are questions and answers and rationales. You can write all of the anatomic locations. You can write all of your med terms. You can write as much as you want in there, with the exception of those 3 things. Good question.
Good answer.
I've done this enough that I know exactly what you can and what you can't write in there. So trust me, whenever I tell you, especially if I tell you, I was just doing a tutoring session with somebody earlier and I told her to write something in there because I even got stumped in the alphabetic index on something. And I was like, you know what? I'm going to follow my own advice. I'm going to write it in the index. So, all right, let's take a look at number 5. So here we have a patient presented with a closed, displaced supracondylar fracture of the left elbow. After conscious sedation, the left upper extremity was draped and a closed reduction was performed, achieving anatomic reduction of the fracture. The elbow was then prepped, and with the use of fluoroscopic guidance, 2 K wires were directed, crossing the fracture site and piercing the metal cortex of the left distal humerus. Stable reduction was obtained with the full flexion and extension. K wires were bent and then cut at a 90-degree angle. Telfa padding and splints were then applied. So what code or codes should we report? Okay. So what is our main term? Remember when I said when we're doing fracture repairs, what's our main term we want to look up in the alphabetic index? Yep, our fracture. Okay. For our fracture, where is our treatment? Where's the treatment directed? What's our anatomic location? The elbow. Yep, perfect. Actually, hang on. Let me reread this real quick. So the fracture is of the elbow. Actually, of our humerus is where the actual repair is being done. You guys see that? I almost did it too, because I just saw it in that top one and I was like, wait a minute. And I remember I picked this one for a reason. So it's actually our anatomic location is the humerus. The anatomic location for the fracture repair, not the fracture, right? The repair itself is done on the humerus. The fracture is in the elbow. Does that make sense? Okay, so we'll go to fracture and then humerus. And then we're going to go to supracondylar, right? Because if we think about, if we fracture the elbow isn't a bone, right? The elbow is just that joint of where your bones go together. Okay. So the anatomic location of it really is the humerus, and it was on the supracondylar portion of the humerus. So we'll go to supracondylar. And then what type of repair did we do? Okay. So we did do a closed repair, right? That closed reduction. So that's part of it. However, when we are using K wires, right? We see that term K wires here. And then we, again, down here, we see that those K wires were bent. When you see that term, when you see that, oh, what's the word I'm trying to think of? When you see that supply or type of procedure that's done, that means that we're doing a percutaneous fixation. So yes, we had a closed reduction, but we also had percutaneous. So that percutaneous, we need to go look at that code description and see what all it includes. Okay. So underneath supracondylar, we'll go look at the percutaneous fixation. And you've got 24538. So it's only a single code. So our code description, yes, K wires. If we use pins or K wires, then that should be your signal to use a percutaneous fixation code. Yep. So your code description for 24538 is percutaneous skeletal fixation of a supracondylar or a transcondylar humeral fracture, and then with or without intercondylar extension. So because we had the percutaneous skeletal fixation, which is your K wires, the anatomic location is that supracondylar fracture of the humerus. And then with or without intercondylar extension, which it doesn't look like we did any intercondylar extension, but because it says with or without, basically, if they did it, great. If not, it's okay. So at that point, our 24538 with the LT to indicate that it was on the left elbow. Again, because we have two arms, we have two humerus, then it's going to indicate that we did it on the left side. So what you can do is at the top of all of your pages for fracture repairs, you can write, I've got it in mind for the book prep that I have. I have percutaneous equals pins or KY. I have that written at the top of every single one of my pages in the musculoskeletal system, just as that verbal or that visual reminder. that percutaneous, if I see those two treatment types with pins or K wires, that means that we have percutaneous fixation. Okay, any questions on that one? Is fluoroscopy included in the code? I would say no, with it not having that. Usually if fluoroscopy is going to be included, actually, no, hang on. Let me think about that for a second. Yes, when you're using yes, sorry, I had to think about that for a second. Percutaneous, when we have that percutaneous treatment, Alex, then we have to see where we're going with that percutaneous treatment, right? So we're going to assume that fluoroscopic guidance is included because we're placing something percutaneously, so we have to know where it's going.
Okay, I have a question about that.
Okay.
Would that would be in the real world setting, but in a testing setting, they're really not listing the fluoroscopy, correct? I mean, because there's no other, I mean, A, C, and D doesn't give you the 24/5/38 option. So at that point, we just forget the fluoroscopy because it's not really listed as one of the options.
Well, no, what I'm saying is in that code does include the fluoroscopic guidance. So in the real world, we would not code it separately. It's going to be included. So we're only going to code the 24538. Sorry if I said that weird.
Okay, thanks. Yeah, that
Yeah.
sounds okay.
Sorry, I thought that was Alex said with the sorry, with the thumbs up. For some reason, my brain just went straight. Yes. So Karen, yes, you're right. So in the real world, we still would not include the fluoroscopic guidance because it is included in that code. So we would not code it separately. Okay. Any other questions on that one? Okay. Let's go to number 6. So we have a 45-year-old male presents to the operating room with a painful mass on the right upper arm. Upon deep dissection, a large mass in the soft tissue of the patient's shoulder was noted. The mass appeared to be benign in nature, and then with deep blunt dissection and electrocautery, the mass was removed and sent to pathology. Okay. So what is our procedure that we did? So what's our main term that we want to look up?
Dissection?
Dissection. Okay. Let's go look and see what's under that. That's not where my brain would have gone, but that doesn't mean that it's wrong. Let's just go look and see what it says. If I know my alphabet tonight. There we go. Okay. Underneath dissection, you've got a couple options. You've got axial vessel, thymuses, cranial adhesions, debulking, donor organ. You've got a couple different things, but I'm not seeing anything in here that would include or that would signal the procedure that we did. So yeah, I've got a couple of the right answers in the chat. So if we go to dissection and we can't find it, right, then let's take a look and let's step back and think. When we dissect something, we're cutting it out, right? We're pulling it out. We're dissecting that mass from the shoulder, right? So we're going to do an excision. Does that make sense?
Yes.
Okay. So you can always go to whatever key term is in there. And then if it's not, like I said, at that point, just kind of step back and look at it big picture. What does that dissection mean? Like, what is a more specific term for that? So we're going to do an excision. And then where is that excision being done? the shoulder. Yep. So underneath shoulder, we only have one option for tumor. So tumor in mass can be considered the same thing. So 23071, 23075, or 23071, 73, 75, and 76. So again, those codes are going to be broken into two different, basically, families, right? So the first family for 23075 is going to be for excision, tumor of the soft tissue of the shoulder area, subcutaneous. And then 23076 family is going to be for excision, tumor, soft tissue of the shoulder area, subfascial. So what do you think we've done here? Do you think this is going to be a subcutaneous or a subfascial? Okay. What's making you guys say subcutaneous? I just want to hear your thought process. Okay, so Dana says because they use the word deep. So the word deep, does that include subcutaneous? Okay, so Alex changed their mind. Just because I ask a question does not mean you're wrong, guys. Okay. Just because I ask a question, I just might want to hear your thought process on it so that you can be confident in your code selection. So in this scenario, even though they tell us that they did a deep blunt dissection, right? Because the tissue, it was in the soft tissue, it doesn't go all the way down into that intramuscular. So they're not telling us how deep they went besides soft tissue. So they're not telling us that they went into the subfascial area, whether they say the word subfascial or they use muscle, bone, whatever it might be, right? So in this scenario, this is still going to be considered a subcutaneous excision. Does that make sense? So then we know we're going to be in that top family. And then our, what's the size of our mass? So if they don't give us the size of the mass, they tell us it's a large mass. So if they don't give us the size, what should we do? Any guesses? If they don't tell us the size of the mass, yep, we're going to use the smallest because we don't have any documentation to back up the 3 centimeter or greater. So if we were audited, then we wouldn't be able to support the 3 centimeter or greater. So in this instance, we're going to use the 23075 because we don't have the documentation. So we just have to use the smallest. Good job. Any questions on that one?
So I have a question about it in the book. It's kind of confusing where I know
Okay.
you said the hashtag, it's recycled number, but why would they put that 23071 back underneath the 23075 above the 76?
Because there's not a code in between the 7.5 and the 7.6, right? So they had to use a code somewhere else and pull it in there. So they're not going to put the 23075 as your parent code. They're going to keep your parent code as your 23075 and then just indicate that it's resequenced and put it underneath because we know that the smallest is listed first and then the larger is going to be listed second.
Okay, I found that kind of confusing. So
I know.
Thank you.
I know. I would lay out the book a little bit different if I had it all up to myself. But I'm just little old me. So Alex, no, I don't disagree with that. I think sometimes that during their meetings they just throw darts at a dartboard and they're like, hey, let's just see what order we're gonna do for codes today. So trust me, it's now I have attended the CPT symposiums when they do go over the releases every year and they have the physicians in the panels and all of the people that basically are in charge of assigning the new codes and all of that. And when they talk about it, it makes sense, but it also isn't the way that like coders may think. So like for physicians, it makes total sense. But sometimes for coders, you're like, can we dumb it down a little bit for us? So I agree. It's sometimes you just kind of look at it and go, not how I would have done it, but okay. Okay. Let's actually skip number 7 because I want to go to number 8 because I want to make sure that we get a little bit of ICD-10 practice. Okay. Because we haven't touched our ICD-10 at all tonight. So let's go down to number 8. So we've got a 50-year-old male that had surgery on his upper leg one day ago to remove an intramuscular tumor. And he presents with heavy serous drainage from the wound. He was taken back to the operating room for evaluation of a possible bacterial infection. His wound was explored down to the rectus femoris muscle, and there was a hematoma that was discovered, which was very carefully evacuated. The wound was irrigated with antibacterial solution, and the wound was closed in multiple layers. So what CPT and ICD-10 code are we going to report? So let's look at it from an ICD-10 perspective first. So what is our condition? What's our diagnosis?
Intramuscular tumor.
Well, we removed the intramuscular tumor one day ago.
Oh, that's right. Okay. Yeah.
Yep. So to make sure you're paying attention to that wording. Trust me, it's not something that everybody does. So yeah, it's the infection. Yep. So we've got that possible bacterial infection. They irrigated it and have the antibacterial solution. So it's going to be our support for the bacterial infection. Okay. So, well, I guess let me rephrase that. It's not necessarily the infection. Let me take that back. It is a complication of the removal of that tumor. Okay. So because they say possible bacterial infection, from an outpatient standpoint, from a professional standpoint, we don't code possible diagnoses, right? Now, we know that it's possible that there's bacterial infection. There's something that's going on that typically should not happen when you have a surgery, right? So that's why we're going to code this as a complication of that surgical procedure. Does that make sense?
So would you look at wound?
It's actually going to be main term complication.
Okay.
Yep. Because we're not necessarily coding the wound, right? Because that wound was there because of the surgery. The wound is not what's bringing him in, right? What's bringing him back in to be looked at again is that possible bacterial infection that is a complication of the surgical procedure that we did yesterday. Does that make sense?
So Tiffany, you would look at the word possible then in order to generate the ICD-10 as
No,
complication?
the
or no?
main term that we're going to look up in the alphabetic index is complication.
But how would you go about choosing that
Because we know from a standpoint that when we do surgeries, any type of possible infection, any serous drainage, all of that kind of stuff does not typically happen, right?
Okay.
So we have to kind of think about what is that considered, right? That's not normal. So if it's not normal, during that healing process, what is it? It's a complication.
Okay, gotcha.
Yeah. Yep. So
Okay.
again, that's what part of why I chose this one, because this is one that it's got a lot of discussion around it, right? So you may not have the exact word that you need in your scenario, right?
Mhm.
But that's where you just need to kind of sit back and think. Now, you do have guidelines about procedural complications. Let me find them very quickly. Let me figure out, well, I use the word very quickly, very loosely. So you have 1B. Let me look at that one real quick and see if that's where it's at. If I can't find it very quickly here in just a second, then I will get it and post it, so that you guys have it in the chat. So that way we're not spending too much time just listening to silence of me just, yep, okay. So it is in guideline 1B16. Does everybody know how to navigate to that guideline? So 1 is going to be your section 1, which is your conventions, coding general coding guidelines, and chapter specific guidelines. B is going to be for general coding guidelines. And then 16 is documentation of complications of care. So if you have the 2024 ICD-10 manual, it's on page G6. And that paragraph basically tells you that you would use your term complication. It extends to any complications of care, regardless of the chapter that it's located in. It's important to note that not all conditions that occur during or following medical surgery are classified as complication. There has to be a cause and effect relationship between the care that's provided and the condition. So in this scenario, they are telling you that he had this surgery a day ago. The same wound from the surgery had that drainage, right? So there's your cause and effect relationship. So that's why we can use our complication. Does that make sense?
So my question is, my thought process was to look at complication and look infection, but I'm having a difficult time finding that. So then would
Okay.
I look at post-op?
You would look under post-procedural, or
Okay.
you can look under surgical procedure, either or.
Okay.
So your complication and then post-procedural, which is a complication has like a ton of pages with it. So then underneath post-procedural, you've got a decent amount of codes underneath post-procedural as well, right?
Right.
However, they give us a little bit more detail. Okay, so we've got this drainage from the wound. I'm going to highlight the things that we need. Once they got in and they explored down to the muscle after they removed that mass, right? Once they were in, they discovered that there was a hematoma, which was evacuated. So underneath complication and post-procedural, then you can go to hematoma of, and then it's of the musculoskeletal structure, right? Because it's down in that leg. And then you have 3 options. Do you see, Karen, do you see where it has that musculoskeletal structure?
No.
Okay. What version of the ICD-10 do you have?
The AAPC?
Is it 2024?
Yes.
Okay, it's on page 102.
Oh,
So your complication is, and so like I said, complications has like 7 or 8 pages of codes, right? So on page 102, you've got post-procedural about a quarter of the way down on that first column. Do you see that?
Yes.
Okay. And then you're going to go to hematoma of, it's about a little bit less than halfway. Do you see the hematoma of?
No.
So you've got cardiac arrest, cardiac functional disturbance, cardiac insufficiency, chorioretinal, following
there it is.
cataract
Okay.
surgery, heart failure, and then hematoma. Okay, so you've got the hematoma.
Yeah.
Now, underneath hematoma, we're going to end in again, and we're going to go down to musculoskeletal structure. It's about 3/4 of the way down.
Okay, I'm looking in the right column now. Yeah, got
Okay.
it. Thank
Okay,
you.
good. Good. I know. I'm telling you, this index
Well, you
sometimes
know
is a
where
little
it
pain.
had me confused is because over on page 103, if you look, it has surgical procedure, but I think I was looking under, because it gives post-surgical procedure on T81-9, but then
So
And-
underneath, so had you gone to that surgical procedure, then you would have still gone down to hematoma.
okay,
It was post-procedural. So then at that point, you're going to see complication post-procedural hematoma. So it's going to send us over to page 102.
okay, I'm just
Yeah.
taking the long way around. Okay.
No, it's fine. It's fine. It's amazing here. I promise you're fine. So underneath your musculoskeletal structure on page 102, you've got following a musculoskeletal surgery, a non-orthopedic surgery, or an orthopedic surgery, right? So for this one, what do you think we'll use? Because it's not an orthopedic surgery, right? But your musculoskeletal is a little bit more definitive than non-orthopedic. You see that? So our ICD-10 code is going to be the following your musculoskeletal surgery. So that gives us M96.840. Does everybody see that? So this is telling us why we're going back in to have the procedure done. We're not doing the procedure because of the tumor. We're not doing the procedure because of the hematoma. We're doing the surgery because of the post-procedural complication that resulted in that hematoma. Does that make sense?
Yes, and this is a good scenario to kind of read it backwards.
Yeah, it is.
Um,
So from a testing perspective, we've got our answer, right? However, let's look at it from making sure we know how to pull the procedure out as well, just in case we're in the real world and we don't have, or let's look at it from potentially like in the future we might have fill in the blanks. So let's look at it and make sure we can pull out our procedure. So let's transition to CPT. Let's get our CPT manual out. What is the procedure that we did? Any guesses?
irrigation and a hematoma was evacuated.
The hematoma was evacuated. Yep. So the evacuation is going to be the procedure. So let's go look at evacuation. I don't know if it's under that one or not, but let's go look at it. Okay. So once we get back to evacuation, there is a hematoma option. However, you only have two options underneath hematoma. You either have for a brain hematoma or a subungual hematoma. So that doesn't match this scenario, okay? Which is fine. We can look in another place. So let's go look at our main term hematoma, because that's what we're evacuating, right? So main term hematoma. And then underneath hematoma, that hematoma was located on the leg, right? So it's of his upper leg. So that gives us 27301. Is everybody at least seeing the alphabetic index where we get the 27301?
Yes.
Okay. Let's just go make sure that that code description matches. So 27301 is for an incision and drainage of a deep abscess bursa or a hematoma. And then it's of the thigh or knee region. So we know that because it's done on the upper leg, it's going to fall in the thigh region, right? So our 27301 is our code. So why do we need to report a 78 modifier with it? Any guesses? Yep. Yep. So it was the unplanned return to the operating room. So technically, if when we're in the real world and we code that without a 78 and we were to submit that to the insurance company is going to say, hey, we've already paid for that muscle tumor or the intramuscular tumor that was removed. That's more than likely got a 90-day global period. So for the next 90 days, any procedures that are done on that site should be included in the payment for that excision of that muscular tumor. However, because it's a complication, it's not something that is typically in that routine follow-up care. So it's going to be a necessary thing for us to go in. So it's going to be that unplanned return to the operating room. So, like I said, if in the real world you submit it without a 78, you're going to get that denied and they're going to say that you've unbundled it from your surgical package. And then you'd have to submit a corrected claim with your 78 modifier on it. Okay. Any questions?
Now this one was a really good one to
Yeah.
choose because there was a lot going on, and you have to really pay attention to the real keywords here.
Mhm, yeah.
This one.
So this was a good example because in both the procedure and in the diagnosis code, your key terms, right? Your key terms are missing. Your key terms aren't given, so you have to kind of think outside of the box. So just in case, if you see something like this on the exam, this one, if you start to get overwhelmed with it, flag it and move on and come back to it later, right? But just remember, I think everybody is kind of like at that learning stage where you're like, hey, I'm going to remember this because I'm going to remember that this doesn't have anything. And I'm going to remember if we see that there's that complication and they're not telling us it's a complication, we're going to remember, oh yeah, we had that one during the study group, that kind of helped. It's going to stick out in your brain a little bit. Okay. Y'all have anything that you want to chat about tonight before, so Xenia, it really depends. Honestly, it depends on the scenario and it depends on your strengths and your weaknesses. Me, personally, I'm a lot stronger in ICD-10 than I am CPT, just because for some reason, like my brain just goes towards the diagnosis and the conditions. So I tend to gravitate towards the ICD-10 first. but
Mhm.
not everybody's brain is going to be wired that way, right? As you
Okay.
go through some examples and more questions that you guys do, that's what's
Mhm.
going to tell you, am I more comfortable and confident in either the alphabetic index of the ICD-10, or am I more confident and comfortable with the CPC alphabetic index?
Okay.
Now, again, I don't want you guys to get too comfortable with multiple choice. So what I've done, I don't know if everybody's opened up the document on Google Drive yet, but I've got your multiple choice here, and then I've got your scratch. So if you guys want to go back through and do these from scratch and not have your multiple choice there to kind of guide you, then the questions are now from starting this week and then moving forward. You'll have not only multiple choice, but you'll have scratch, and then underneath that you'll have your answer key that still gives you your answers and then your rationale. So these are on, hang on, Karen, real quick. I'm going to answer Myra's question and then I'll, so Myra, these are located on the Google Drive that are within Discord. Okay, Karen, what was your question?
So the format of the blanks that you put at the end, because I didn't get a chance to print those off today.
No, you're fine.
Was this kind of the similar formatting that they may possibly have in the newer tests coming later on?
Yeah. So the versions of the beta that I've seen, I guess let me rephrase what I'm about to say. I have not seen the beta version of the exam. I have seen the practice exams that have had fill in the blanks in them. So the way that they do it is over on the right hand side of the screen, you'll see your scenario. Okay. So all of this is going to be on the right hand side of the screen. On the left hand side of the screen, it's going to say what CPT code or codes would be applicable. And then it's going to have a blank for each code that should be there. So if you have 2 CPT codes, then you might have 2 blanks, right? So Stacy, you're saying it has 5 fill in the blanks, but you may have only needed 1 code. Is that what you're saying?
Yeah, well, actually, there was a couple of codes. I was,
Mhm.
I'm kind of practicing for obviously my exam next month, and I was like, I did A and B, and then I went to C yesterday. I'm like, oh my gosh, I have to fill in the blanks,
I know.
But
That was
I figured
all of everybody last week. We were like, whoa, where did these fill in the blanks come from?
I assume they're just doing it to get a feel for how long it's going to take us all to do, because I mean, I finished my practice with 1 minute, and I was stressed, I guess, on the last 5.
Well, so the beauty of the practice exams is AAPC doesn't actually collect the data for how long it takes people to do the practice exams, because you can go out and go in and you can start it and stop it and all of that, right? They are doing a beta testing internally. So I don't know if they're having like certain students do it. I don't know if they're having certain employees do it. I don't know how they're beta testing it. They've only just told us that the beta testing is in progress. I wish they would be a little bit more transparent about it, but that's all that we know. So, Lakasha, we don't know when the fill in the blanks are going to start. We just know that it's going to happen at some point. The practice exams now include your fill in the blanks. But don't be scared of it, guys. I don't want you guys to be scared of it, okay? Because you're gonna have to fill in the blanks essentially when you're in your real world job, okay? So you have to get used to filling the blanks at some point. Most of your exam is probably going to be multiple choice. They haven't told us how many of the questions are going to be multiple choice versus how many are going to be fill in the blanks. Again, I'm kind of in the dark, just as in the dark as you guys are, right? They haven't released anything to us as AAPC instructors yet to tell us any details of it. But I know that some of the structures of the other exams, like for instance, the certified inpatient coder, that one has only 10 questions that are fill in the blank. Okay. So I don't think that they are going to make it a majority of the test that's fill in the blank. If they did that, they would definitely have to expand the time. I don't know I don't know if they're planning on extending the time. I don't know if they're planning on keeping the time at 4 hours and just, taking out multiple choice and then adding some fill in the blanks. We don't really know. As soon as I find out that information, I will let you know. I promise. Like, you guys will probably be the first to know in the Discord group. But I don't know. I wish I could give you all answers, but like I said, I'm just in the dark as you guys are with the fill in the blanks and things like that. So that's why I'm making sure that I give you all resources to practice your fill in the blanks. Yeah, guys, let me get that link for the Discord. If anybody has Discord open, I don't have it open at the moment. So I'm gonna have to open it and it's gonna take a second to load. But if anybody's currently in Discord, if you want to grab that link. But just get comfortable enough with learning how to code from scratch and using your alphabetic index and doing those things so that even if they were to announce today that fill in the blanks start tomorrow, that you guys are confident and comfortable and it's not going to be this huge wave of anxiety and everybody freaks out, right? So if we can get comfortable with it now, then the more comfortable that we get with it. Thanks, Dana. I was actually getting ready to grab it. So Dana's got the link for the Discord in there. But the more comfortable that you guys get with fill in the blanks now, the less of a shock it's going to be when it actually happens. Okay. So every week there's going to be the fill in the blank options. It's the exact same questions, right? But it is going to be just fill in the blanks down here. So the ones that have like the different units, that's what this means, is it's got a code and then times X units, right? And then if you've got CPT and ICD-10, then I've got the section for both CPT and ICD-10 down here. So any other questions that you guys want to chat about? Okay. If you all think of anything whatsoever, don't hesitate to go in the Discord group. I see a couple people joining it now. So don't hesitate to ask questions throughout the week during the Discord group. Obviously, if you're part of the Facebook group, you can ask them in there too. But anything that is, anything that I get information wise about any testing changes or anything like that, then I'll make sure that you guys are the first to know. Okay. All right, everybody. Thanks for having a good night. Chat with you soon. It's starting to rain here, so hopefully my dogs are not going to lose their ever loving mind for the rest of the night. But you guys have a good rest of your evening, and I'll chat with you next week.